Bronchopulmonary dysplasia is the leading chronic lung disease of prematurity, arising from disrupted lung development and postnatal injury. It imposes a significant clinical burden, as affected infants frequently require prolonged supplemental oxygen or respiratory support and have high rates of hospital readmission. The condition has multi-system implications. Growth failure is common due to increased metabolic demand and feeding challenges. Oral motor dysfunction can complicate nutrition, and neurodevelopmental risk is elevated, particularly in extremely preterm infants exposed to prolonged mechanical ventilation, intermittent hypoxemia, or inflammation. The care footprint for BPD is substantial. Infants often have extended neonatal intensive care unit stays and require multidisciplinary follow-up spanning pulmonology, cardiology for pulmonary hypertension surveillance, nutrition and feeding therapy, and developmental services. Management must integrate respiratory support with attention to growth, cardiovascular stability, and neurodevelopment, reflecting the systemic impact of chronic lung disease in this population. Understanding the scope of BPD informs anticipatory planning, resource allocation, and the need for structured, individualized follow-up to optimize both short and long-term outcomes. Lung development proceeds through a series of well-defined stages: embryonic, pseudoglandular, canalicular, saccular, and alveolar. In the late saccular and early alveolar periods, which coincide with the preterm window, rapid alveolar septation occurs along with capillary proliferation, expanding the surface area available for gas exchange. Surfactant production matures during this stage, stabilizing alveoli and enhancing compliance. The structural maturation of the alveolar capillary interface directly drives functional outcomes. Increased alveolar number and capillary density improve compliance and ventilation perfusion matching, allowing efficient gas exchange. Disruption during this critical window, as occurs in extreme prematurity or with postnatal injury, compromises alveolar architecture and vascular development, setting the stage for bronchopulmonary dysplasia. Recognizing these developmental milestones is essential for contextualizing the timing of injury, anticipating vulnerability to ventilator-induced trauma, and guiding early interventions such as gentle ventilation, oxygen titration, and pharmacologic support to protect ongoing lung growth. Bronchopulmonary dysplasia has evolved in its histologic and clinical presentation over time. The old BPD, seen primarily in preterm infants exposed to prolonged high oxygen and invasive ventilation, is characterized by extensive fibrosis, cyst formation, and airway metaplasia. Imaging shows coarse reticular changes with marked heterogeneity, and management historically focused on treating established scar disease. In contrast, new BPD predominantly affects extremely preterm infants and results from disrupted alveolar and vascular development rather than postnatal injury alone. Histologically, lungs exhibit simplified alveoli, reduced secondary septation, and impaired microvascular growth. Typical triggers include extreme immaturity compounded by multi-hit exposures, such as intermittent hyperoxia, infection, and variable ventilatory pressures. Imaging reveals subtle hazy opacities, patchy atelectasis, and reduced compliance with ventilation perfusion mismatch. Clinical management of new BPD emphasizes growth promotion, vigilant monitoring for pulmonary hypertension, and lung protective respiratory strategies, reflecting the altered pathophysiology and reduced fibrosis compared with the historical phenotype. The core pathobiology of bronchopulmonary dysplasia centers on developmental arrest of the lungs. Alveoli are fewer and larger. Secondary septation is impaired, and acini are simplified, resulting in reduced surface area for gas exchange. The vascular bed is diminished, and dysregulated pulmonary vasoreactivity predisposes to pulmonary hypertension. Injury inputs compound this developmental arrest. Mechanical forces, including volutrauma, barotrauma, and atelectrauma from invasive ventilation, disrupt delicate alveolar and airway structures. Oxidative stress from hyperoxia overwhelms immature antioxidant defenses, while inflammatory insults, including chorioamnionitis, sepsis, or ventilator-induced cytokine release, further impair alveolar and vascular growth. The repair milieu is also disrupted, with extracellular matrix remodeling causing elastin disarray, altered transforming growth factor beta signaling, and disturbed vascular endothelial growth factor pathways, all of which hinder normal alveolarization and angiogenesis. Together, these developmental and injury-related processes produce the characteristic structural, vascular, and functional abnormalities seen in BPD, explaining persistent oxygen requirements, susceptibility to pulmonary hypertension, and long-term respiratory morbidity in preterm infants. Prenatal factors play a pivotal role in shaping lung vulnerability and subsequent development of bronchopulmonary dysplasia. Placental malperfusion and intrauterine growth restriction limit nutrient and oxygen delivery to the fetus, constraining lung parenchymal and vascular growth. Doppler studies revealing abnormal umbilical or middle cerebral artery flow, along with ultrasonographic evidence of growth restriction, identify infants at higher risk for impaired alveolarization and pulmonary vascular development, setting the stage for postnatal pulmonary hypertension. Anticipating these issues allows early planning for aggressive nutritional support and careful hemodynamic management immediately after birth. Intrauterine inflammation, such as clinical chorioamnionitis or histologic evidence on the placenta, primes the fetal immune system and heightens susceptibility to subsequent postnatal inflammatory insults, including sepsis or ventilator-induced lung injury. These prenatal inflammatory exposures may alter cytokine profiles, upregulate pro-inflammatory mediators, and disrupt normal signaling pathways like transforming growth factor beta and vascular endothelial growth factor, leading to abnormal alveolar and microvascular development. Antenatal corticosteroids are a critical protective factor. When administered appropriately, they accelerate surfactant production, enhance alveolar stability, and improve early lung compliance, reducing the need for prolonged mechanical ventilation. The timing, dose, and completeness of the steroid course are crucial, as incomplete or delayed administration diminishes these benefits. Collectively, these prenatal contributors, placental insufficiency, growth restriction, intrauterine inflammation, and corticosteroid exposure, interact with postnatal events to determine the severity and trajectory of BPD. Understanding these mechanisms enables prenatal risk stratification, guides perinatal planning, and informs early postnatal interventions to mitigate lung injury and optimize long-term outcomes. The early postnatal period is critical in shaping the trajectory of bronchopulmonary dysplasia, as interventions and exposures during the first 2 weeks of life can profoundly influence lung injury and repair. In the first 3 days, careful titration of oxygen is essential. Both hyperoxia and hypoxia contribute to oxidative stress and impair alveolar and vascular growth. Success on the first intubation attempt is important to minimize repeated airway trauma, while early use of continuous positive airway pressure or non-invasive ventilation pathways can reduce ventilator-induced injury. During days 4 to 7, cumulative oxygen exposure becomes a key risk factor. Maintaining synchrony on mechanical ventilation is critical to prevent atelectrauma and volutrauma, and strict infection prevention practices reduce inflammatory triggers that exacerbate lung injury. By days 8 to 14, the focus shifts to avoiding repeated intubations, managing fluid balance to prevent pulmonary edema, and ensuring adequate nutritional intake to support growth and tissue repair. Adequate protein and caloric provision during this window is essential to promote alveolar and vascular development, support weight gain, and optimize long-term pulmonary outcomes. These early postnatal modifiers interact with the underlying lung immaturity, prenatal exposures, and genetic susceptibility, collectively determining the severity of BPD. Proactive management during these critical periods, balancing ventilatory support, oxygen exposure, infection control, fluid management, and nutrition, can mitigate ongoing injury and improve the likelihood of favorable long-term pulmonary function. Inflammatory and injury biomarkers provide insight into the pathophysiology and potential risk stratification of bronchopulmonary dysplasia, though their routine clinical application remains limited. Early cytokine and chemokine profiles, including elevated interleukin-6, interleukin-8, tumor necrosis factor alpha, and monocyte chemoattractant protein 1, have been associated with increased likelihood and severity of BPD. These markers reflect activation of the innate immune system, either from prenatal exposures such as chorioamnionitis or from postnatal insults including ventilator-induced injury and sepsis. Oxidative stress readouts, such as elevated 8-isoprostane protein carbonyl content and nitrotyrosine levels, indicate reactive oxygen species, mediated damage to alveolar and vascular structures. These oxidative modifications disrupt surfactant function, impair alveolar septation, and contribute to abnormal microvascular development. Angiogenic biomarkers, including vascular endothelial growth factor, placental growth factor, and shifts in soluble receptors, correlate with impaired vascular growth and the risk of pulmonary hypertension. While these biomarkers are primarily used in research or for risk stratification, they highlight the multifactorial injury pathways driving BPD, integrating mechanical, oxidative, and inflammatory insults. Understanding these biomarker patterns informs both the conceptual framework of disease pathogenesis and the potential timing of preventive interventions, such as antioxidant strategies, anti-inflammatory approaches, or modulation of ventilatory and oxygen exposures during the first critical weeks of life. The airway and oral microbiome in preterm infants plays a significant role in the pathogenesis of bronchopulmonary dysplasia. Early colonization patterns, assessed via tracheal aspirates or saliva samples, reveal that low alpha diversity and shifts toward pathobiont-dominated communities, such as ureaplasma or mycoplasma species, correlate with increased BPD risk. These microbial patterns may exacerbate local inflammation, impair alveolar and vascular development, and interact with systemic immune responses to potentiate lung injury. The timing of specimen collection is critical. Early life sampling captures initial colonization, while repeat sampling can track dynamic changes related to infection, ventilation, or antibiotic exposure. Clinical application focuses on antibiotic stewardship, treating documented pathogenic burden rather than empirically administering broad-spectrum antibiotics to minimize disruption of the developing microbiome and reduce secondary inflammatory hits. Understanding the microbiome's influence on BPD emphasizes the need for careful monitoring of infections, judicious use of antimicrobials, and integration with other preventive strategies, including non-invasive ventilation and nutrition optimization. This approach supports preservation of beneficial microbial communities, mitigates inflammatory injury, and complements mechanical and pharmacologic interventions aimed at reducing the incidence and severity of BPD in extremely preterm infants. Genetic factors contribute to individual susceptibility to bronchopulmonary dysplasia, as evidenced by twin concordance studies and familial clustering that cannot be explained by environmental exposures alone. Candidate pathways implicated include genes involved in inflammation, antioxidant defenses, extracellular matrix and elastic fiber biology, and angiogenesis. Variations in these pathways may modulate the infant's response to oxidative stress, inflammatory insults, and mechanical ventilation, influencing the severity of alveolar and vascular injury. Despite these associations, the clinical application of genetic testing remains limited. There is currently no routine genotyping to guide bedside care or therapeutic decisions, and genetic information is primarily used in research settings to identify high-risk populations, inform mechanistic studies, and potentially target novel interventions. Recognition of genetic susceptibility helps contextualize why some preterm infants develop severe BPD despite similar prenatal and postnatal exposures, reinforcing the multifactorial nature of the disease and the need for individualized, multifaceted management strategies. Pulmonary hypertension is a common and serious complication in infants with moderate to severe bronchopulmonary dysplasia. Disproportionate hypoxemia relative to lung parenchymal disease often signals pulmonary vascular involvement, and rising carbon dioxide levels on stable ventilatory settings may indicate impaired pulmonary perfusion. Echocardiography is the primary non-invasive tool to assess pulmonary vascular pressures and right ventricular function. Key parameters include tricuspid regurgitation, jet velocity to estimate right ventricular pressure, septal flattening, pulmonary artery acceleration time, shunt direction through a patent ductus arteriosus or foramen oval, and evaluation of right ventricular performance. Growth and feeding status provide additional context, as poor weight gain and desaturation during sleep or feeds may reflect underlying pulmonary hypertension. Early recognition of BPD-associated pulmonary vascular disease allows timely initiation of interventions, including optimized oxygenation, judicious use of diuretics, and targeted pharmacologic therapy such as sildenafil, improving both immediate stability and long-term cardiopulmonary outcomes. Bronchopulmonary dysplasia involves both airway and parenchymal dysfunction, which significantly influences ventilatory management. Lung compliance is often reduced due to simplified alveoli, disrupted extracellular matrix, and persistent atelectasis. Adequate positive end expiratory pressure is essential to maintain alveolar recruitment and prevent atellect trauma, while avoiding overdistension that could worsen injury. Airway resistance is variable, particularly in the presence of small airway disease or malacia, which can cause expiratory flow limitation and dynamic collapse. Continuous assessment using pressure volume loops, flow volume curves, or other bedside graphics can help identify overinflated or under-recruited lung regions, guiding ventilator adjustments. Understanding these mechanics is crucial for selecting appropriate ventilatory strategies, tailoring non-invasive or invasive support, and optimizing gas exchange while minimizing additional injury to fragile, immature lungs. Bronchopulmonary dysplasia presents with distinct clinical phenotypes that reflect the relative involvement of parenchymal, airway, or vascular components. In the parenchymal predominant phenotype, persistent oxygen requirement is associated with atelectasis or hyperinflation. Ventilator strategies focus on optimizing positive end expiratory pressure and tidal volume to prevent further injury. Airway predominant disease, often involving malacia of the large or small airways, manifests as expiratory wheezing, poor response to bronchodilators, and dynamic airway collapse, requiring tailored non-invasive support and sometimes surgical intervention for severe obstruction. Vascular predominant phenotypes feature disproportionate hypoxemia and poor growth due to pulmonary hypertension, with clinical signs including oxygen desaturation during feeds or sleep and echocardiographic evidence of elevated right ventricular pressures. Identifying the dominant phenotype guides targeted interventions, informs monitoring strategies, and supports individualized care planning. It allows clinicians to anticipate complications, adjust ventilatory and pharmacologic support, and optimize long-term respiratory, growth, and cardiovascular outcomes in infants with BPD. The diagnostic framework for bronchopulmonary dysplasia integrates gestational age, the course of respiratory distress syndrome, cumulative oxygen exposure, duration of mechanical ventilation, and infection history. Early screening includes monitoring growth, feeding tolerance, desaturation patterns, and aspiration risk. Defining BPD relies on established criteria such as NIH/NICHD or Jensen classifications, typically assessed at 36 weeks postmenstrual age. Phenotyping further characterizes infants as parenchymal, airway, vascular predominant, or mixed, allowing tailored interventions. Baseline evaluations include trends in blood gases, chest radiographs, echocardiography if pulmonary hypertension is suspected, and nutrition panels. The diagnostic framework informs individualized respiratory support tiers, nutritional strategies, and pulmonary hypertension surveillance schedules, with reassessment every 1 to 2 weeks to track progression and guide therapy. This structured approach ensures accurate classification, risk stratification, and optimal timing of interventions to mitigate long-term morbidity. The classic NIH/NICHD definition of bronchopulmonary dysplasia is based on oxygen exposure and respiratory support requirements in preterm infants. Infants are considered to have BPD if they require supplemental oxygen greater than 21% for at least 28 days. Severity is then assessed at 36 weeks postmenstrual age. Mild BPD is defined as the need for supplemental oxygen at 28 days, but breathing room air at 36 weeks. Moderate BPD includes infants requiring less than 30% oxygen at 36 weeks, whereas severe BPD is defined by oxygen need of 30% or greater and/or positive pressure support, such as CPAP, nasal intermittent positive pressure ventilation, or invasive mechanical ventilation. These criteria help standardize classification, guide clinical management, and facilitate comparison across studies, although practice patterns such as oxygen saturation targets and interface selection may influence the assignment of severity in individual units. The Jensen 2019 classification refines BPD severity by categorizing infants based on the type and level of respiratory support at 36 weeks post-menstrual age, rather than solely oxygen exposure. The scale progresses from room air to low-flow nasal cannula, high-flow nasal cannula at 3 liters per minute or greater, CPAP, or nasal intermittent positive pressure ventilation, and finally to invasive mechanical ventilation. This approach provides a stronger prediction of later morbidity than oxygen-based criteria alone, capturing the functional impact of persistent ventilatory dependence. Explicit grading according to respiratory support improves clarity for cross-study comparisons and allows for phenotype-specific interventions. Documenting the exact grade informs prognostication, guides ongoing care, and facilitates research by providing a standardized framework for assessing treatment efficacy and outcomes in preterm infants with BPD. Chest radiography in bronchopulmonary dysplasia provides insight into structural lung changes and guides clinical management. Typical findings in new BPD include hazy reticular opacities, patchy areas of atelectasis, and regions of hyperinflation. These patterns are subtler than the coarse fibrosis and cystic changes observed in old BPD, but still indicate impaired alveolar development and ventilation perfusion mismatch. Radiographic evolution may show persistent heterogeneity, with focal lucencies suggesting air leak syndromes or lobar collapse. Imaging findings correlate with clinical severity and inform decisions regarding ventilatory support, oxygen titration, and monitoring for complications such as pneumothorax. CXR remains a primary bedside tool for tracking progression, detecting acute events, and supporting phenotypic assessment, particularly in infants with ongoing oxygen requirements or those at risk for pulmonary hypertension. Computed tomography and advanced imaging modalities provide detailed structural assessment in bronchopulmonary dysplasia, supplementing chest radiography. CT can quantify air trapping, linear opacities, architectural distortion, and the presence of bullae, which are critical for understanding the extent of parenchymal and airway injury. These structural findings correlate with pulmonary function measurements, such as forced expiratory volume and diffusing capacity, offering insight into long-term respiratory outcomes. Advanced imaging is particularly useful in refractory or severe BPD cases, guiding evaluation for pulmonary hypertension or surgical interventions, and is often employed in research settings to monitor disease progression. Photon-counting CT or high-resolution modalities can detect subtle parenchymal changes not evident on plain radiographs, allowing precise phenotyping of disease. While these techniques are not used routinely at the bedside, they inform individualized management, track response to therapy, and provide prognostic information regarding lung growth, functional reserve, and long-term pulmonary function. Optimal oxygen management in bronchopulmonary dysplasia balances adequate tissue oxygenation with minimizing oxygen toxicity and oxidative lung injury. Unit-specific SpO2 targets are typically set between 90 and 95%, with higher thresholds maintained in infants with pulmonary hypertension or severe disease, ensuring saturations remain above 92% during sleep and feeding. Alarm strategies are essential to maintain patient safety while avoiding alarm fatigue. Sensible low limits reduce nuisance alarms, while continuous review of time and range histograms helps evaluate oxygen exposure over time. Early stewardship includes monitoring cumulative oxygen exposure from the first minutes of life, adjusting FiO2 before modifying flow or pressure, and reassessing after changes in feeding, weight, or clinical status. Properly calibrated targets and alarms facilitate lung protective strategies, guide titration of respiratory support, and reduce the risk of exacerbating lung injury, while providing a framework for standardized care and continuous quality improvement in the NICU. Prevention of bronchopulmonary dysplasia begins immediately in the delivery room, targeting strategies that reduce lung injury during the critical window of early postnatal adaptation. Interface selection is central: continuous positive airway pressure or nasal intermittent positive pressure. Ventilation is preferred over immediate intubation when the infant's respiratory distress is moderate, as non-invasive support minimizes barotrauma and volutrauma. The interface choice is individualized based on gestational age, lung compliance, and severity of surfactant deficiency. Ventilation strategy emphasizes low tidal volumes, minimal pressure swings, and careful monitoring of chest excursion and gas exchange. Overdistension of hypoplastic alveoli or uneven ventilation can exacerbate lung injury, so precise adjustment of positive and expiratory pressure and inspiratory pressures is critical. Oxygen is titrated along pre-established SpO2 targets in the first 10 minutes of life, balancing the risks of hypoxia and oxidative stress. Excessive oxygen exposure is a known contributor to BPD pathogenesis. Pharmacologic adjuncts, particularly caffeine, are introduced early to enhance central respiratory drive and improve diaphragmatic contractility, supporting spontaneous breathing and facilitating non-invasive support. Additional preventive measures include minimizing handling to reduce oxygen demand, maintaining normothermia, and ensuring appropriate fluid and hemodynamic management. These delivery room interventions, by reducing initial lung injury and promoting effective alveolar recruitment, set the foundation for improved postnatal lung growth, reduced ventilator dependence, and ultimately a lower incidence and severity of BPD in high-risk preterm infants. Prevention of bronchopulmonary dysplasia begins before birth and continues through the immediate perinatal period. Antenatal corticosteroids, administered according to obstetric indications, accelerate fetal lung maturation, increase surfactant production, and improve lung compliance, thereby reducing the severity of respiratory distress syndrome and subsequent exposure to mechanical ventilation. The timing and completeness of steroid administration are critical, as incomplete courses provide less protection against BPD. Perinatal strategies include delayed cord clamping or intact cord stabilization when feasible, which improves hemodynamic transition, enhances placental transfusion, and supports early pulmonary perfusion. Infection prevention is also a key component. Early identification and treatment of maternal and neonatal infections reduce inflammatory hits that exacerbate lung injury. Targeted antibiotic therapy, rather than broad empiric coverage, is preferred to minimize disruption of the developing neonatal microbiome, which is increasingly recognized as a contributor to BPD risk. Delivery room management aligns with these prenatal strategies. Infants are supported with gentle ventilation, low tidal volumes, and careful oxygen titration. Caffeine therapy is initiated early to stimulate central respiratory drive and facilitate non-invasive support. Collectively, this antenatal and perinatal bundle integrates pharmacologic, respiratory, and infection prevention strategies to mitigate early lung injury, optimize alveolar and vascular development, and reduce the overall incidence and severity of BPD in preterm infants. Surfactant administration is a key component of BPD prevention, and delivery strategies are tailored to minimize lung injury while ensuring effective alveolar recruitment. The INSURE technique is best suited for infants with severe oxygen requirements and clear respiratory distress syndrome. It involves brief intubation, surfactant installation, and rapid extubation to non-invasive support. This approach minimizes ventilator exposure and reduces barotrauma and volutrauma. LISA, less invasive surfactant administration, or MIST, minimally invasive surfactant therapy, is preferred in moderate respiratory distress or when CPAP is effectively maintaining oxygenation. A thin catheter delivers surfactant while the infant continues spontaneous breathing on CPAP, avoiding positive pressure ventilation and supporting lung protective strategies. Successful implementation requires skilled personnel, appropriate pre-medication policies, and clearly defined rescue criteria for intubation if CPAP alone is insufficient. Selecting the appropriate surfactant technique based on severity, lung compliance, and available expertise optimizes alveolar recruitment, reduces ventilator-associated injury, and contributes to lower BPD incidence. Both Ensure and LISA/MIST emphasize early alveolar stabilization while preserving non-invasive support, aligning with lung protective principles in extremely preterm infants. Early pharmacologic interventions target modifiable pathways to reduce the incidence or severity of bronchopulmonary dysplasia. Caffeine is the cornerstone therapy, enhancing central respiratory drive, improving diaphragmatic contractility, and facilitating earlier extubation. Early initiation, particularly within the first days of life, reduces apnea severity, minimizes intermittent hypoxemia, and may indirectly mitigate ventilator-induced lung injury, contributing to lower BPD risk. Vitamin A supplementation in extremely low birth weight infants supports alveolar epithelial development and has been associated with modest reductions in BPD incidence. Delivery logistics, dosing, and availability affect effectiveness, and careful monitoring is required for toxicity or absorption issues. Macrolide antibiotics are used selectively for documented ureaplasma or mycoplasma colonization, as these organisms have been linked to postnatal inflammation and increased BPD risk. Routine empirical therapy is discouraged to preserve the neonatal microbiome and prevent resistance. Integrating these early pharmacoprevention strategies with optimal ventilatory management, oxygen titration, and nutritional support provides a multifactorial approach to minimize lung injury during the critical early postnatal period, improving structural and functional lung outcomes in preterm infants at highest risk for BPD. Management of bronchopulmonary dysplasia is multifaceted, requiring simultaneous attention to respiratory support, nutrition, and comorbidity management. Respiratory strategies prioritize non-invasive support with oxygen, CPAP, or nasal intermittent positive pressure ventilation, reserving invasive mechanical ventilation for infants who fail non-invasive measures. Individualized weaning plans are guided by lung mechanics, oxygen requirements, and overall clinical stability. Nutritional strategies are central, with aggressive provision of calories and protein to support alveolar and vascular growth. Weekly monitoring of weight, length, head circumference, and electrolyte balance allows adjustment of fortification, supplementation, and fluid management. Comorbidities such as gastroesophageal reflux, aspiration risk, and infection are actively managed, with feeding interventions and preventive strategies to reduce respiratory decompensation. This stepwise, integrated approach addresses the multiple contributors to ongoing lung injury, supports growth and development, and reduces the risk of BPD progression. Structured protocols and regular reassessment ensure that interventions are tailored to individual infants, optimizing long-term respiratory, cardiovascular, and neurodevelopmental outcomes.